had talks about water, you've had talks about air, and you've had talks about different things. But actually, what does that mean for us every day in practice? What are the things that we can do to think and prepare ahead of time so you, like me, don't suffer from the Friday afternoon phone call that means you're trying to phone around going, what on earth do I do? Which is, to be honest, most of my career, like most of infection control from my point of view, is about who you know as your phone a friend on a Friday afternoon who's just going to help you out. So hopefully this will help you arrange a little bit of your phone a friend before you need to get there. I have a long-standing history in the environment. I did my PhD in the role of the environment in cross-transmission of infection, and I did it when it really wasn't sexy to do it, right? I mean, not that I think it's particularly sexy now, but at least you get invited to speak to people. When I started doing it, and I tried to publish papers, I got a lot of responses back going, but why? Like, why do we care? Because the standards are all about visibly clean, aren't they? Now, I don't think I have to preach to the choir here, but microbes can't actually see them, right? And therefore, having a visibly clean standard for how we work in healthcare possibly doesn't make the most sense. But that leaves us in a real gap, a hole about what do we do. Because if the standards all say that if it's visibly clean, it's fine, but we still know we're getting acquisitions, cases, organisms that are happening that are not obeying that visibly clean is fine standard, what do we do to actually act and make things better? So we're going to talk a little bit about what the evidence is. I know you've heard a lot about it today, but I'm hopefully going to try and put some of that together about why it's a bit less straightforward sometimes than we'd like it to be. We're going to talk about techniques for mapping transmission, thinking about where your risks might be, both kind of in the moment, but also ahead of time, so that if something happens, you can be like, okay, so this is what I'm thinking about in this space. We're going to talk about options to identify where that problem is, if you start to feel like there's something going on. And then kind of some key considerations that you can think of that either may help stop there being a problem to start with, or at least give you a list of actions that you can think about when you have something going on. But first I'm going to quickly talk about what I mean by the environment. And I am a holistic kind of girl. I don't like to exclude anyone, even the bugs. So as far as I'm concerned, your environment is anything in your air, water, or on your surfaces. So it's basically anything that's within that space. And we tend to refer to that as the built environment. And the built environment, I think, is one of those key things. I talk about a triumvirate. So often we think about patient and bug, right? So your patient's got their underlying conditions, their factors, and then we think about the organisms that they've either got on board or they may get exposed to. But to me, actually, we're missing a key component of that, and it's actually a triangle. So really, you've got your built environment, your patient, and your bug. And the reason for that is a lot of the way that your built environment works can either stop there being a problem or make your problem so much worse. And I have been on both sides of that coin, where I've thought it's going to be fine, and it hasn't been fine. And the other thing to think about with your environment is it's bi-directional, right? In the same way that you as a person has a microbiome, and you have your bugs that are different to my bugs, that are going to be more similar to someone in your household's bugs, your environment is the same. So we published an interesting study in a new build, so 2 different wards, so an ENT ward and a respiratory ward. And they'd just been opened, and we sampled just their sinks, actually, for the first 6 months. And what we discovered is that a lot of the colonizing flora came from the patients that were in those spaces. So the sink microbiome in my ENT patients, completely different to the sink microbiome in my respiratory ward. And that's important because how many times do we decant a ward and move someone else entirely in there? So then you've got this whole different set of bugs that are going to be exposed to patients and exposed from patients that is completely different to what they originally had. And so when we think of the built environment, we actually have to think about how that dynamic works both ways. It isn't just a one direction, what our environment gives to our patients. It's actually what we give back to that built environment that's going to stick around even after that patient has left. And that brings us on to, I think you'll probably have heard a lot about prior room occupation risk. So, as I said, no one massively cared about the built environment and environmental transmission when I started work, but we cared about it because I work at Great Ormond Street, right? My kids crawl around, lick the floor, put anything on the floor in their mouths. They will do everything. They're learning to walk. They'll stick their hands in their nappies and then grab the wall. And so for us, it made a lot of sense that the environment was an important thing in a way that might not be so obvious if you're just sitting in an adult centre or an adult surgical intensive care where people are sedated and not moving. So I think that's why it was so important. And we knew back in the 2000s that if we put a patient in a room that had previously had an adenovirus positive patient in it, and BMT unit, that patient was more likely to acquire adenovirus. And we didn't have the fancy American data for that because, like, our rooms were recorded in paper diaries. And so we didn't have the lovely digital data that they have. But from the early 2000s, we've been screening rooms before we put a new patient in it because adenovirus can have a mortality of 50 to 80% in pediatric BMT. So the consequences of getting it wrong makes the resource required to get it right make sense in that setting. And what people have found is that outside of things like adenovirus, which again, I know I'm a retro girl, it was really cool in the 80s and no one cared about it forever until recently during COVID when suddenly I was popular again and people phoned me because of adeno-associated virus. But, you know, it's the best virus, so people should care about it a bit more. But different organisms work in different ways. And so some organisms are much more likely to contaminate your environment, then they will stay in that environment. So things like VRE, which are harder to clean away, things like C. diff, where you have to use special chemicals in order to actually get them to be removed, they will survive and linger, and then they have to get back into the patient that goes into that space. And so that's why there is this data that shows that for certain organisms, you have a much higher chance of acquiring an infection with that organism if you go into the room after someone else has been in that room with that organism, compared to going into the room next door on the same ward that didn't. So that implies that there is a continuation risk, and that's most likely linked to the environment. But the thing that makes it harder is that we can't treat all bugs as if they're the same, right? Bugs are like people. They behave in different ways. They have different things that irritate them, and they have different things that make them happy. And so things like adeno will happily survive for 3 months on a surface. We've had an MRSA in a ventilation duct that survived there for a year and then just broke down and deposited like rain on anyone who came into the room. And so that variation, though, does make it tricky. And the variation of the fact that some of this will come from things like water. Some of it, as I just said, with my Staph aureus, was in a ventilation grill. There's been lots of things about Acinetobacter and in intensive care ventilation. And some of it will be linked to your surfaces and stuff that gets put down on a surface and doesn't get removed. And some of that with your viruses, because I like to talk about viruses as well as bacteria and fungi, because pediatrics, right? My guys will stick 100,000 copies of something down. Whereas if you're looking at a bacteria, most of these standards are linked to bacteria, you're looking at a few hundred. So if someone touches a surface with a contaminated hand with bacteria, you're thinking 300 to 500 CFUs. If someone has a diarrheal moment or vomits with norovirus, you're looking at 100,000 copies, and you're asking your cleaning to do the same thing with that much more. So sometimes these cleaning failures are not failures as such. We're just asking something that could never be achieved. And so there are times when you have to think about, should I just be cleaning more than once? But that is organism dependent and route of transmission dependent. And even outside of the organisms and the spaces that we've just talked about, if you have a standard exposure moment in a 4-bedded bay, would you expect every patient in that 4-bedded bay to go on and acquire or become symptomatic? The answer is usually no, right? They don't all have the same risk. And the same is true for data like this. So this is a C. diff outbreak paper. And people often say, well, it's not consistent. So you can see that I've got my patient on day 1 who's got C. diff. The green patient gets discharged. The blue patient comes in. The blue patient stays for a bit and gets discharged. The orange patient comes in. He gets C. diff quite far into his stay. Now, the C. diff was probably always in that room, but the patient that is blue probably didn't have the same risk factors as the patient that is orange. And so we can't just say, because there's this delay and it wasn't immediately afterwards, that it isn't about that environmental loading. And this is true in my case in pediatrics, and I'm going to talk pediatrics again. So if I had a 2-year-old who acquired C. diff, they are not as likely to get significant disease as if it was a 16-year-old. So if that blue patient is a 6-week-old who's not really engaging with their environment, who's not really at such great risk, and then I put a 16-year-old in afterwards, that doesn't mean that it isn't the room that has actually been the C. diff risk. And that is what the complication of some of these things are when we're using traditional infection control thinking about how to control that risk and whether I've got something going on. And so what we really need to think about is, how do we identify we've got a problem? How do we understand that problem enough to put an intervention in place? And then how do we use that intervention to actually solve the problem? Like, how do you know when it's finished? Because in something like a traditional norovirus outbreak, you will wait your 72 hours from the last person then and not get any ongoing symptomology, right? If you're talking about an environmental outbreak, I've had ones that run for over a year. How long do you wait until you say you've got it under control? Because resource is limited for all of us right now. And some of this is all about type of exposure. So, sometimes you can see it. I have a Victorian hospital. I have a lot of floods. I have a lot of things that just kind of leak everywhere. And so sometimes you come down and you know what? It's fairly straightforward. You can see you have a problem. That doesn't mean the solution is easy, but you can see it's there. I have a lot of traumas. That's an air ventilation gauge, like a manual one. The number of times people tell you that they have been wrong for like weeks, and you put all kinds of patients in there. And so trying to do things like get people to tell you on the day the gauge goes wrong, so you can do something about it. Even that is a baseline battle, but at least you can see, potentially, that it's not right. And oh my God, the removal of the ceiling tile. I'm just like, people, it's a giant hole. Can you not, did it not occur to any of you that it was a bad thing to put a patient underneath the giant hole in the ceiling? So it's not simple even when we can see it, right? And risk assessing some of this stuff is not simple. So understanding what the risk of a ceiling void is to a non-immunocompromised patient is actually challenging to work out. It requires a lot of understanding of what your organisms are, what the patient's situation is, and how long it's happened for, and why on earth did they open the ceiling tile in the first place? Because, if they opened it up to drill in there, it's a very different risk to if they just opened it up to take a peek about where some electricity wires were and closed it again. So even the obvious stuff is kind of hard, but at least we know that it's happened. One of the other challenges, and I know you had a lot of conversations about sinks earlier, is that some of this stuff is not obvious. So there's lots of data now that shows that sink droplets can spread for 2 meters from a sink when you turn it on. And that's a problem because the guidance says you only have to be 1 meter away from a sink. So a lot of our buildings were designed when sink placement wasn't such a significant thing. I also published a paper that says, if you don't use a sink, shocker, the microbes grow. So if you have sinks that don't get used, actually that's a problem. If you have sinks that do get used and are less than 1 meter from your patient bedhead, that's also a problem. The thing is, it's really easy to think that we have to do things like sink removal and all of those things in all of these scenarios. But we also have sinks there for a reason, right? And so actually, the onus is upon us to go, does that sink need to be there? Can that sink be somewhere else? Are there other things we can do to control that splash risk? The solution is sometimes to remove it, but it's not always going to be. Again, pediatrics. My patients are in nappies, people. If you've got a BMT ward with lots of patients with mucositis and diarrhea, you're not gelling that away. It's not going to be nice. So, hand washing is still going to be important, but it's about thinking about placement. And when you're doing things like thinking about outbreaks, it's about thinking about, is there something that's going on? There's a really old paper now, but it was really good, from the States. They didn't have any Pseudomonas bacteremias, apart from in this one bed space, where anyone who stayed more than 7 days got a Pseudomonas bacteremia. And it's because the sink was basically my elbow length from the head of the patient. And so they were basically just drowning them in it every time they suctioned. And the other thing that makes it complicated is we tend to think about, and people talk a lot about environment in terms of high touch points. Now, I am not telling you that high touch points don't matter, but they're not actually the be-all and end-all. So this is some work that we did actually as part of my PhD, where we looked at a surgical intensive care unit and a medical intensive care unit in adults, because, occasionally I step outside the hospital and go and do other things. And they, just to show you that, yes, there were bed spaces where the ventilation didn't circulate as well, right? There were bed spaces that were always slightly higher loaded. But also, some of our highest risk came from the high-level surfaces, because no one reaches up to clean. And in this intensive care unit, that was a real problem, because they stored all of the pillows on top of the storage. And then they took the pillows down in order to manipulate and move a patient, putting it in close and direct contact, and then put it back up onto the high-level storage. And so in that circumstance, if all of your deposition is happening on top of your pillow, and then you're smacking it right against the patient that you're then moving, it's an issue. We have lots of data that has sort of shown that, we have known for a long time that sink spaces do need specific risk assessment, because in terms of microbial loading, they are the highest loaded spaces in any environment. And that's because in our case, it's where you take yourself to remove your organisms. So yeah, there will be organisms there. So sink cleaning, I had a conversation earlier on today, slightly obsessed with sink cleaning SOPs in a way that probably isn't normal for any normal person, and I acknowledge that I'm not. To the point that there is a YouTube video on how to clean your sink and how to clean your shower that I did with the Royal Society of Public Health, because it is not simple. And we do things like we incorporate a flush in every sink clean we do. We dry sinks before we clean them, because otherwise, if you put your cleaning chemical on there, you're not going to have the concentration you think you have. you're not going to have the concentration, and you have to leave it for a certain amount of time before you then carry on cleaning. And all of these things are going to be really, really important for you. And just to depress you even more, this is some work. There's a paper. I know, I'm a geek. From the 1990s, where they released cauliflower mosaic virus DNA into a ward and looked at how it spread. And you know, there are no cauliflowers in my hospital, so there was no real risk of infecting someone with cauliflower mosaic virus DNA. But it hadn't been repeated because people freaked out about releasing a virus, even if it could only infect cauliflowers. So I had a PhD student recreate cauliflower mosaic virus DNA in homage, and we put it in 3 spaces. So we put it in a reception area, on a play table where mostly kids and their parents would interact. We put it on a treatment room mouse, so only staff members should interact. And we put it in an isolation room, where, you know, we do all of this stuff so it doesn't get out. And then we swabbed back after 8 hours and then every day, just to show how far and how many other sites. So we swabbed 48 other sites around that ward. It went in 8 hours, and then how it looked after 24, 48. And you can see just how far things spread. And all of this was loaded at the kind of load that a single hand wash or a single wipe should have been able to remove it. And the most interesting thing for me is you don't just get the one marker. You end up getting those markers coalescing. And that's really important when we think about organism risk, because if you have an Enterobacter with an imp that then lands next door to a sensitive Klebsiella, that gene exchange is going to happen, and then you're in trouble, because that Klebsiella is going to be harder to get rid of and is more likely to get into patients, and then suddenly you're losing treatment options. And so the fact that these things move together, and the fact that over the course of a day, you can get spread to so many other sites, means that even if you have a single cleaning event once a day, that probably isn't going to cut it for you. So you have to think about risk as dynamic. And that's really important when we start to talk about screening, because people will do one-off screens and will just screen like randomly. If your movement is dynamic and you don't understand where things move to, and this is one of the reasons we did this, is to understand, if you do this in a cardiac unit, these move to completely different places, because the way you care for those patients is different. How much they get up and move around is different. And so we have this one-size-fits-all approach to our cleaning, a lot of the way that we do our interventions, when actually this work shows that you really need to have something that's more customizable for where your transmission and movement routes actually are. So how do we work out what to do? My biggest plea is to really think about what your question is. Because often, and I've been there myself, you act because you've got something going on and you feel like you need to do something. But if you act without thinking, and if you act without deciding what your question is, you'll get answers you don't understand. And that can lead you down completely different rabbit holes. So really think about, am I trying to identify the source of something? Have I got an outbreak? Am I trying to think about actually what that route might be? So like I had a Malassezia furfur, right? I was pretty sure that it probably came from something the patient was having put on them by their families. My microbiology colleague was like, well, it's all going to be in your ventilation. I'm like, I don't think so. But it's a fair question. And it's a fair question that requires you to do things in a different way in order to work it out. Whereas if you go down a rabbit hole, like if you have, for instance, an Acinetobacter and you only think ventilation, or if you have a Pseudomonas and you only think that sink in that patient room, you can miss a whole load of other risk. So you can miss the fact that it could have come from a theatre, right? You could be looking in entirely the wrong place, or you could be following something that isn't a solid chain of thought. So mapping is useful, and sometimes that mapping is just going and walking around. Validation, knowing that the tools you're using can answer the question that you've got. Trend analysis is really helpful. So we do a whole load of routine screening. We look at also, though, routine infections. So I sit down every month and look at every waterborne pathogen in a trend analysis graph to go, do I have a higher than expected level? Am I outside of my 2 standard deviations? Because I'll never pick it up if I'm looking case by case. The numbers are too small. Whereas if I sit down and look at my entirety of my data, it gives me a different solution. And surveillance is key. And for some things, routine surveillance may be the answer. It probably isn't for most of the stuff that most people encounter. But it is worth it in some circumstances in my world. And you have to think, does person, place, and time cut it? If I can have an outbreak that happens over the course of a year, you may not fulfill person, place, and time. You know, that's a direct point source kind of way of looking at things. So what do you have in your toolkit that enables you to think about ways outside of person, place, and time, like the trend analysis? What surveillance do you need? What risk assessments have you got going on where you have awareness that you might look at certain places differently because they have different risks? So in my case, my pediatric B&T unit, I look at differently than I might do my short stay surgical. And what alerts and other things are coming out? And then you put that all into your risk assessment. So what are my possible routes of transmission? What are my loads in terms of, is it a virus? Am I going to have really high patient loads? Is it a Candida auris, where actually you may not need high loads in order to have a problem because it's so hard to remove? Because all of these will link back into your interventions. What does your environmental persistence look like for what you think you've got going on? And also, I love timing of infection. I love the 48-hour rule. Not at all, in a world where most of my stuff is viral, and many of those viruses will have a 5-day incubation period. And so you have to think of your data, like there's the data that you think of in order to do our mandatory reporting right and actually talk about that kind of it's in or it's out. But then there's the data that we look at that tells us about risk, and they are not necessarily the same things. They're both important, but they are different. And so in terms of things that will help you think about where you need to look for stuff like this BSI document that just went out last Friday about Pseudomonas and other waterborne pathogens that will talk about how you should be thinking about sampling, when you should be thinking about sampling, what organisms might you consider, how might you need to do it. There's things like field safety notices that tell you about stuff like your heater-cooler units and what might be needed. So use what's out there as a starter for 10, as well as thinking about your own clinical environment and your patients. Walk around. The things I find when I walk around, because I'm like, it's fine. No one would ever do that. And then I open a door and I'm like, someone did that. So I have found clinics in places you shouldn't find clinics. I have been to other hospitals to help walk around and found, you know, people cleaning stuff in dirty stores, but also like ventilation things ducts that have not been connected, and everything you think you can find in terms of patients in storerooms. Because they were like, well, the parents were okay when we went and visited another trust and they needed a bed. People change environments all the time. And they whack a new label on that door and think that fundamentally changes the space inside. But a treatment room has 10 air changes per hour, and it's a specific environment. You can't just label something a treatment room or a sterile store. It doesn't magically change the space. And you have to think about how you test, and your labs are going to have to know how to use these things and see if they've got them. So all of this needs planning ahead of time. If you are going to do air sampling, then you need to know what your air sampling interpretation criteria are. Not everyone is going to have contact plates sitting around for consumables. So there's no point in deciding that that's what you'd use if you had an outbreak if you're not going to have access to it. So think about what you might need ahead of time. And then sadly, you're going to have to put in a bunch of work because the interpretation criteria for most of these things are not available. I spent 5 years working up an interpretation algorithm to interpret adeno-CTs because they're not available to us. We have interpretation criteria for theatres, but only at commissioning and validation when they are empty. So knowing what matters when you've got a ventilation-based outbreak, like if you find 2 colonies of MRSA, is that normal? Like, what would you do about it? For the new guidance, we're currently doing a point prevalence of all of our augmented care because it says you have to have an outbreak policy related to water. But if I don't know, if I sample my sinks right now, I'm going to get a Citrobacter or a Steno, and then I only sample when I've got an outbreak and I find a Citrobacter or a Steno, I'm going to reinforce the fact that that's the source, when actually that could just be there all the time. And so if you haven't done this stuff before, so we have what we call the microbiological sampling of the environment policy. I told you, I'm a geek. But it is really useful because it's publicly available to anyone that needs it, that then says how we sample, what we sample for, and how we interpret what we find. So that if it comes to it on a Friday night, you're not trying to work out if 10 CFUs of something is important. I'm running late, I'm going to hurry up. If it's of any use to you, there are papers out there. We did a review that talks about, at least for some surface sampling, what you might want to consider, but it is going to be personal to what your centre is and what your risks are. So I would just encourage you to think about it before you'd ever need it. And in terms of interventions, it's all about how we come together to get it right. This is a multidisciplinary problem, and it requires multidisciplinary solutions. So you will need input from your domestics and your cleaning staff. You'll need input from your engineers. You'll need input from IPC, but you'll also need input from the clinical teams that use that space and know how it is used, because you won't be able to bring that kind of information. You can then only interpret and talk about issues. And so we're not going to be able to do this elimination or substitution, right? These things are going to be there. What we have to do is think about what can we do better in terms of some of our design and engineering? What can we do better in terms of our education so people do the right thing? And, you know, last ditch, do some PPE, but we kind of want to be focused on the other things. And so when you're bringing stuff in, make sure that it's got the design that is needed to do the thing you want to do. Please don't just buy any air filtration piece of kit and think it's going to be the same. This stuff is really complicated, and this is where your phone of friends are really helpful. Don't just buy some water solution that's sold to you. Know what your results look like and what your rooms look like, and think about things like your wipes. Like, not all wipes are going to do the same thing, and your risk dictates what your approach should be. And finally, do be prepared for the unexpected. The reason this biscuit tin is here is I had a year-long norovirus outbreak, and I screened everywhere, people. I looked everywhere. I screened the toilets were amazing. The biscuit tin had over 100,000 copies of norovirus on it. So every time a member of staff took a biscuit, they gave themselves noro, and then they managed to pass it on to 3 patients who excreted it for a year. So there are lots of ways these things could be a problem. Think about how the environment influences your occupants as well as the other way around. If you're going to do something, prepare for it so you know how to use the results, and use everything you've got to make the best decisions possible. Thank you very much.